Thanks very much. I have a disclosure. I'm not a huge fan of big doses of opioids in sedation, but I do have good news. I don't think I'm going to tell you anything today that you don't know already, so I think we'll also make up some time. But what I do suggest that we do is that we quickly run through the slides and then have a group discussion based on your clinical practice and your experience, because I think in this room there's probably more cumulative practice experience than in most textbooks, and it would be good if we could learn from one another and have a bit of a discussion afterwards. So this is the crystal structure of the opioid receptor, and it's not that little block that we saw years ago in our second year physiology classes. The outline of my talk is we're going to quickly run through the opioid principles, quickly run through pharmacology, kinetics, and dynamics. I'm not going to dwell on context-sensitive half-time because I think you've had a lot of that already. We're going to quickly look at costs, ease of use, say something about combination therapy and safety. There's one thing new, but I'm not sure how relevant it's going to be to our practice, and then we're going to have a group discussion. So just to quickly wrap up, the opioids are semi-synthetic or synthetic ligands at the G proteins. The old classification of the different receptors and what they did, the mu1 ones were giving us analgesia, and the other ones basically all the side effects. And then, as you already know, it gives good analgesia and sedation, but no amnesia. And then always bear in mind the synergistic effects with the CNS depressants. Now, at the bottom here, we have an illustration of the G-coupled protein receptor, and it crosses the cell membrane 7 times. It has certain domains on the outside of the cell where ligands can bind, and then it has certain receptor sites on the inside of the cell membrane where secondary messenger molecules will bind, and I'll come back to that a little bit later. And basically, if we stimulate this receptor with an opiate, it depletes calcium and it inhibits the voltage-gated calcium channels. The kinetics, we all know that we can use them orally, transmucosally, transdermally, IM and IV. Once again, we've mentioned this earlier, the onset. It's important to think about whether they're non-ionized and lipid soluble, because that means they're rapid and short-acting. There are differences in how well they bind to the receptors, and then the redistribution is basically initially to muscle and fat. The highly lipid-soluble ones can accumulate in plasma. If you use very long infusions, there's also the possibility of them accumulating in the lungs and getting a secondary effect of leaching back into the circulation. This slide gives a summary of the relative potency, onset, and duration of these opiates. But this is all relative. It depends on how much you use, if you use them repeatedly. But we had to sort of do something to just illustrate the different potencies. And we can probably discuss this because some people might say, in my clinical practice, I don't find this is relevant. I find that those doses don't actually make sense. But in general, most people might agree that a dose of 50 mics of fentanyl as a bolus would give you a peak onset in about 3 to 5 minutes, and it would last for about half an hour. So I'm not going to run through all of them now because I think all of us are familiar with these. I just want to point out with remifentanil, the relative respiratory depression is quite marked, and there are some experts who actually advise that we do not use remifentanil as a bolus at all. I'd like to hear your opinion on that as well. This is just a quick comparison of the peak effect times, and you'll see that we've included morphine and hydromorphine there as well, just to illustrate how different they are to the shorter acting opiates. If we then look at their metabolism, they all metabolize by the liver, with the exception being remifentanil, which is broken down by plasma esterases, which makes it relatively independent of liver metabolism. And the metabolites get excreted via the kidneys. Just a quick slide again to remind about the context-sensitive half-times. fentanyl being the mischievous one amongst them. But it really comes into play once you start to give infusions or repeated boluses for more than 2 hours. So in shorter sedation procedures, where most of our practice probably lies, under an hour, they're basically all very similar, and there's not much to choose in terms of this when you come down to less than an hour. If we look at drug interactions, just remember the monoamine oxidase inhibitors and the antidepressants. I think we're going to have a lecture on that later again today. Just a quick word again about serotonin syndrome, as Professor Ruloso mentioned. Most often seen with tramadol and pethidine, but it has been described with all of these short-acting opiates as well. There are case reports. Patients would then present with fever, sweating, shivering, myoclonus, agitation, confusion, and it can lead to death. We're not aware of any deaths with the short-acting opiates, but with tramadol certainly. In patients who are taking psychiatric medication, bear in mind that one of the differential diagnoses would be neuroleptic malignant syndrome, which can be difficult to distinguish from this. The one clinical clue is, and it is a clinical diagnosis, the serotonin syndrome is excitatory. It's because of an excess of serotonin. So you'll get things like myoclonus, where the patients who have the neuroleptic malignant syndrome have a deficit of dopamine, and they tend to be lead pipe rigid. They won't have myoclonus, and that's a clinical clue. If you can elicit clonus, it's probably this. If you can't, and if it's a lead pipe rigidity, then it's probably not this. Then I drew up this slide just as a comparison to try and get an idea of cost. But having said that, there's so many things that one needs to take into consideration. Whether you're sharing ampules between patients, if you treating patients on a fixed cost basis where you have to absorb some of the costs, if you're working in an environment with cost constraints where you might not want to use something that's slightly more expensive like remifentanil, but then again, if you can share it between multiple patients, it becomes cost effective. So I've put this down here as an example, but obviously there are so many things influencing this that this is not the end all and be all. And then again, if you look at the cost of an ampule, the variation, and if you see that in terms of the total cost of a procedure or a patient's total hospitalization cost, it's really small. I always like to compare costs in anesthetic to theater time per minute. And if you bear that in mind, this is probably less than a minute. So, and always bear in mind as well, it also depends on whether you combine your opiates with alpha-2 agonists, ketamine, benzos, propofol, and narcoleptic agents, and then once again bear in mind safety. So what's new? At the end of 2020, this new opiate was registered by the FDA. It differs from the other ones in the sense that if you look at the secondary intracellular mechanisms that happen when you bind at the G protein receptor, there are polypeptides called arrestins that come into play. The arrestins move to the cell surface, and they basically act as brakes on the opiate receptor, and they then also help to internalize the receptors as well, but they in themselves also have effects. Opiates also bind to the arrestins, and they often cause, or well, they do cause a lot of the side effects that we see. So what they try to do then is to develop opiates that are more, they tend to rather elicit the G protein effects of the binding and not elicit the beta-arrestin effects, thereby decreasing the side effects, specifically respiratory depression. It's expensive. I'm not sure how much of it is used in the States at the moment, but this is the only new thing that we have on the short-acting opiate horizon at the moment. And then I need to give some context for this bizarre image on the right-hand side here. A friend of mine dabbles in amateur photography, and I recently started to generate AI images, and I asked him to generate an image for me for this presentation depicting someone skinning a grape with a samurai sword, because I wanted to convey the message that you can basically use any of these opiates. As long as you know what you're doing and you bear the basic principles in mind, it doesn't really make that much of a difference. And that's why I'd like you to share with us now your personal experiences and which opiates you prefer to use and why you feel comfortable with them as opposed to the other ones. Okay. Would anyone like to volunteer their favorite short-acting opiate and why? Well, let me ask this question. Does anyone here do sedation for colonoscopies? Okay, so there's several people there. How many of you prefer to use fentanyl? Yes, that's relatively few. L14? A lot. Remifentanil? Some. And this sort of mirrors what I've seen in the practice where I work as well. There are two endoscopy suites that I work in. I've had a look at the drug books. Very few people use L14. A lot of people use remifentanil and a lot use fentanyl. And they all do good jobs. And all their patients are happy. And the surgeons or the physicians doing the colonoscopies are happy. So I think my take-home message is you can use any of these as long as you adapt your practice for your specific setting, your specific colleague who does the procedure, and the patient that you have. And then bearing in mind this excerpt from the SASA guidelines, if you can keep it simple, that's probably the best way to do.